Hi, everyone. Welcome and thank you for attending today's webinar, Population Health Innovations Post-COVID-19. What is new for our students? Presented by Springer Publishing Company and featuring the editors of the recently published textbook, Population Health Management, Strategies, Tools, Applications, and Outcomes. My name is David Diadana, and I am the senior editor responsible for the Public Health and Health Administration publishing programs here at Springer Publishing. For those who do not know much about Springer Publishing, we are an independent publisher known for innovative textbooks, professional references, and clinical products in the fields of nursing, behavioral and health sciences, and medicine. Before I introduce the presenters, please note that this webinar will be recorded, disseminated, and posted on our website in case you missed any part of the presentation. And we will also be taking a few questions at the end of the presentation from the audience and through the Q&A feature on Zoom. Please feel free to send along any questions as we go. I am delighted to introduce our speakers for this presentation. Dr. Annie Hewitt is acting chair for the Department of Interprofessional Health Sciences and Health Administration and professor at Seton Hall University. She also serves as the director of the Elizabeth A. Seton Institute for Community and Population Health. She regularly publishes in health-related peer-reviewed journals and is currently on the Journal of Health Administration Education editorial board. Her honors include Distinguished Service Awards from professional health executive organizations, such as the American Lung Association, the Healthcare Planning and Marketing Society of New Jersey, and the Association of Healthcare Executives of New Jersey. Julie Mascari is a healthcare executive with over 20 years of experience and is currently the regional president of Humana. Julie's responsibilities include managing the overall performance, development, and expansion of Humana's business presence and financial success in the Northeast region. She's an adjunct professor at Seton Hall University, has a master's in health administration program, Rutgers University School of Pharmacy, and for Hackensack's Meridian School of Medicine. Steve Wagner has been active in the healthcare field for more than 45 years, focusing on the US system and its ongoing transformation. He has extensive experience as a textbook author, teacher, researcher, and healthcare executive with a long career in medical practice administration. Dr. Wagner served as an executive at the Carolinas healthcare system for 20 years until retiring in 2015, when he became a full-time faculty member at Seton Hall University and its executive in residence for the Master of Healthcare Administration program.
Well, thank you, David. I really appreciate that. And I'd like to welcome all of you who have joined us today from the 4 different allied health programs around the country. We're pleased that you are here with us. I thought before we started on the first of our 3 innovations that we probably should all get on the same page regarding population health management. So I wanted to describe it slightly for you. This is our perspective. And that is that population health management is a unique combination of essential health approaches. And it all begins with defining the populations, recognizing the impact of the entire healthcare sector, and also implementing those management skills. As you probably recognize, population health management is very focused on outcomes, and the outcomes are covered in health effectiveness, cost efficiency, and also a focus on the determinants of the quality of life. We also should at this point address the slight confusion that people have between population health management, and public health. Population health management is distinct and different from public health. Although having said that, let me also say that it does borrow some of the best practices from public health, like managerial EPI, but it also uses approaches from community and global health as well. And finally, we need to address those 2 ultimate goals of population health. Just like our Healthy People 2030, the major goal is providing quality of healthcare services to all Americans. But our second issue is also focusing on providing the right care at the right place, at the right time, by the right provider, and of course, at the right cost. So if we can move on to our first topic, which is the rise of consumerism. I know it's difficult to think that we are moving to post-COVID, but we are definitely there. So let's go on and discuss healthcare consumerism. On the left-hand side of the slide, we share a relatively new definition of healthcare consumerism, but I think it's one that resonates with all types of healthcare providers. It is people proactively using trustworthy, relevant information and appropriate technology to make better informed decisions about their healthcare options. This definition has two important challenges for population health management. The first one is the recognition that patients are now consumers. And as consumers, they require autonomy, the right for them to make choices. The second major challenge is that the consumer will make decisions about where and how they receive healthcare going forward. And part of those criteria now will include convenience, as well as patient satisfaction and consumer satisfaction. And that all equals to trust. The next slide, we're going to talk about the four most, I think, impactful drivers of change on population health that are resonating out of this increase in healthcare consumerism. We all know that COVID-19 disrupted the traditional healthcare model of patient communication, interaction, and treatment. We know this because we found through research, we know that 1/3 of all older Americans postponed their regular caring during the past 2 years and some months. We also know that the number of ambulatory care visits for elective or minor care also decreased by about 60%. We put all this together, and what we're saying is the access to care and the traditional issues of interaction were essentially dissolved during the pandemic. So it has accelerated consumerism. And we're going to talk about the next three drivers of change, specific components. So during this time of this parallel adoption of consumerism, we also know that there was another situation going on, and that's our second driver of change. That's the adoption of virtual care, or if you prefer to use the term telehealth. The second consumer innovation is that technology allowed us to integrate that entire healthscape so that we had digital access. And of course, most of that came through our mobile devices, because they allowed us freedom to access communication, treatment, or even follow-up with our healthcare providers. Patients quickly became used to that autonomy and also the ability to seek healthcare information elsewhere. The American Hospital Association just reported that there are currently 350,000 health-related apps that the public can access off of their phone. And that leads us directly to our third driver of innovation, that rapid adoption of technology disrupted the common traditional pathway between the providers and patients. So what we see and what we saw and are continuing to see, I should say, is a lack of continuity of care and is a disruption of that coordination care network between the primary care provider and the local community hospital. If we have digital health and e-health, we don't have to be concerned about where we live, the geographic location, because we have another option to address and to take care of our basic healthcare needs. So that typical care coordination was directly challenged. And our final and fourth major transformation of change from consumerism was a loss of loyalty. Due to all three of these three factors, what we now know is that brand loyalty to my primary care physician or to my healthcare organization, that local community hospital, it's diminished now. We have a loss of loyalty. The healthcare system is no longer in control. Consumerism has replaced brand loyalty. And the perspective is healthcare is now a commodity. But we also see coming out of that a blending of what I'd like to address on the next slide, and that is the combination and the synthesizing between patient experiences and consumer experiences. Patient experience, explained in the definition on the right-hand side of your slide, highlights individual perceptions of the healthcare interactions with the health provider and the environment. It's those interactions that remain with the individual. Consumer experience is broader, of course, and it focuses on different satisfaction criteria, such as ease of use, general convenience, timeliness, and does it fit within their individual lifestyle. So seeking out healthcare is no longer just a health visit, it's a shopping experience. Next slide, please. This is going to challenge all of our faculty, and we experience it as well, to help our students understand healthcare consumerism, the model. And one of the tools that we have introduced is this model, meaningful consumerism, to our students. And you can see built within these 5 criteria and characteristics are skills that our students need to learn. So in step 1, we're looking at shared decision-making, which is giving that patient now that's a consumer a sense of autonomy. And the second one, we're looking at decision-making, a partnership. Our third requirement focuses on transparency, which is sometimes, I think, lacking in healthcare, but not so much in other retail experiences. Our fourth criteria is the ability to share, communicating, disseminating, and implementing evidence for our patients that are now with a consumer hat on. And finally, the last step is understanding that it's a reciprocal arrangement between the consumer participation and the patient provider. So once students have learned these skills, we move on to talk about another common model that resonates, I think, with both our health students and the general public as well. And that's called the consumer health decision-making model. There are 6 steps in that. They're all relatively simple. Most of us, when we make decisions, don't even recognize that we are going through this individual process. For the first step, the health issue recognition is the individual patient saying to themselves, do I have a health problem? That quickly moves on to, what do I know about it? Internal search. What do I know about it? Step 3 then moves out to external searches or information. And we know that most people will immediately turn to the internet to get that information. Step 4 is, how do I make the best choice? 5 is, once I've made the choice, how do I go about purchasing it or aligning myself with that health provider or organization? And then finally, step 6 is that satisfaction. How happy am I with that experience? All of those are valuable. And we find that students generally, they grasp this model without any difficulty at all because they can relate it to themselves. However, I do want to show you 2 scenarios. And here's our first scenario that illustrates the use of the decision-making model. And in this scenario, it's Stephanie, and I'll give you a minute to read it. So as you can see in this model, the decision process of making, that Stephanie is definitely very motivated, immediately takes the initiative and almost follows the model step by step. Each of her interactions are seamless and they are enhanced by meaningful consumerism. Let's move on to narrative number 2, and this is Melissa. In the second scenario, Melissa delays any decisions, but eventually assumes the consumer role. And because of the health system's integrated consumer and technology capacities, she enables the individual meaningful consumerism with everybody that she is interacting with. So we have the patient and consumerism satisfaction all taken care of in one particular case. So as a summary, I hope I've been useful. This talk has been useful for you as sharing a little bit about our first innovation, which is consumerism and its impact on population health management. I just put together a few quick summary questions for you when you're working with your students. Do they recognize the importance of consumerism? Can they link meaningful consumerism with patient and provider engagement, what they do? Are you teaching them strategies that can help improve those patient and consumer satisfaction scores that are so valuable now, especially since we're getting to value-based reimbursement? And finally, could your students apply this consumer health decision-making process in their own lives? At this point, I think I'm going to pass it on to Julie and to our second innovation.
Thank you, Annie. I appreciate that. So as Annie just shared in the 2 narratives, both pregnant patients are managing their care differently. So in this section, we're going to dive into how we assess risk and healthcare segmentation, and we're going to walk through those opportunities. So on the next slide, as a healthcare professional, as we outlined at the very beginning of this presentation, I'm assessing risk and I stratify populations to achieve health outcomes in pretty much everything I do all day long. I'm a P&L owner, so it's very important to me that I am also assessing how those health outcomes are going to improve the bottom line. So it's really important that we are breaking out those patient panels to ensure that we are touching those members or those patients, and we're influencing care and impacting care. So when we think about risk management relative to population health management, the biggest difference between population health and other delivery approaches is the ability to define discrete populations and tailor the specific interventions to improve health outcomes. This is a critical element of managing populations, especially within those high morbidity and vulnerable populations. And I will tell you, as a Medicare leader and someone who serves that population each and every day, this is a critical stratification effort so we can make those interventions. So there was a time in my career that I led a complex care division. We focused on the highest cost patients with the largest opportunity to impact change. For example, stratifying them into those patients that had a caregiver and were engaged with their care, we knew that this cohort of patients would probably be impacted, more likely, we'd be able to reduce their costs and improve their care. If the patient wasn't responsive, didn't return calls or any correspondence, it was very possible that we couldn't improve their care. We couldn't help them, and overall their expenses would go up. With the challenges of managing costs and resources, it's critical to leverage your assets to achieve the best outcomes. So as we think about the next slide, students will learn in this section the tools and examples to enable them to segment and stratify a population. These include identifying the priority population. For example, in the previous narratives, pregnant women that are addressing their care in different ways. Or if we look at a high risk, high acuity population, and did they get any sicker because of COVID-19? We need to assess the patient's needs and risk. And why do we do this? Understanding their risk and predicting future risk is really important. For example, if they have cancer and are undergoing treatments, it's likely that they will be at higher risk of COVID unless they were in recovery. Once we have stratified the populations, broken them up into groups, and categorized them by high, medium, and low, we can outline interventions to improve their outcomes. Again, using the patient undergoing cancer treatments. We would stratify them as high acuity, high risk, and many would have interventions that probably included sending them home meals, giving them PPE, even giving them free Zoom so they could stay at home and isolate, but at the same time, they could be connected so they weren't social isolated, which is really critical, especially during those COVID times. Lastly, we need to measure the results and see if we indeed saw a reduction in COVID cases in those cancer patients undergoing treatment. If they were getting their PPE at home and they were getting free Zoom to stay in touch with their children, and we were providing those home meals, the likelihood is that they probably wouldn't get COVID. So it was critical that we segmented the population and implemented those interventions in order to improve their health outcomes. These are just a few types of segmentation and the process that I do every single day when I'm assessing the patient populations that I serve in all of the states that I work in at Humana. When we look at the next slide, how do we define risk? So we look at risk factor, the score, segmentation, and stratification. So I just shared the process when the risk is identified. We need to understand a score so we can measure it. So for example, there's a Medicare risk adjustment factor. It's known as a RAF score. This is the calculated score that CMS uses to identify the acuity of a Medicare patient to determine the multiplier of the premium. So it's really simple. The sicker the patient, the higher the acuity, the higher the RAF score, the higher the premium. Those patients with higher RAF scores are then segmented to be assigned interventions so that we can lower their cost and improve their health outcomes. So that's just one example of a risk factor and how it can be defined in healthcare. On the next slide, here's a simple population health matrix. It's used on a regular basis. It's something that I use as a healthcare leader to determine priority populations, how to categorize them by risk levels or scores, and their future risk to build interventions. This enables us to ensure our focus and our prioritization. So very simply, as you look at this, if you look at this graph, you can see what are the patient's symptoms on the left, and then looking at are they low, medium, or high, and the intensity that that patient is feeling or their symptoms, and then you're going to build those interventions around them. So in summary, on the next slide, the chapters that we've identified will teach students what metrics to use to identify populations at risk. For example, medical cost, RAF scores, admits per thousand, just to name a few. Once we've identified which populations to focus, how you determine the levels of risk, for example, high, medium, or low, or if you're doing an outreach campaign, phone, email, SMS, text, what interventions will you implement? Once you've stratified them, who prefers email? What will the message say? When will you send it out? What is your call to action? And lastly, what outcomes are you expecting? Once you send the email, and the patient responds to the call to action, what was your open rate? Did they go to the doctors? Did they have a better outcome? These are just a few of the key items your students will learn in this chapter. This is a real life example of what my teams do every day to ensure that the populations that we serve are being managed in a very micro level. We don't want to boil the ocean and do the exact same interventions for every single member. Everyone is unique. We want to stratify them and identify their risk and understand the impact we can actually make. We like to use the term surgical. We're very surgical in our approach in order to impact outcomes to ensure that our time, our energy, and our money is spent wisely, and moreover, we're maximizing all the limited resources that we have. So this is just an overview of this section and another innovation that that can be implemented. Now I would like to turn over the presentation to Steve Wagner. He's going to discuss our ACO innovations addressing health equity.
Well, thank you very much, Julie, and welcome. Let me add my welcome to everyone on the webinar today. And yes, I'm going to talk about the new ACO innovations that are addressing health equity. And because ACOs have been around a while, but Medicare has adopted a new strategy with it, which we'll talk about a little bit more as we go through this part of the presentation. It is a fairly complex topic, so we'll just touch the surface on it. Next slide, please. So first of all, let's talk about an ACO and what it is. And basically, at its core of every ACO is primary care physicians. In fact, by definition, you must have primary care physicians to have an ACO. The other elements can vary from ACO to ACO, and they may be under one roof or one organization, or they could be contractually put together. So the Accountable Care Organization is a network of providers with the purpose of providing better care through coordinating that care and also using rigorous data analysis to try and improve cost. And it does also involve a shared risk and shared reward model. Next slide, please. So COVID really underscored some of the necessities that ACOs are working with the community to serve the needs of the vulnerable and the underserved. And I think that certainly COVID showed us many things that we needed to improve in our healthcare system. And we also know that certain communities were affected a lot more than others because they did not have access to resources, information, and simply they were in a bad situation relative to other parts of our community. Next slide, please. So one of the approaches is really to think about health in all policies. You know, we have had such a siloed approach to health in this country for many, many years. The healthcare system stood fairly independently, and we all looked toward the healthcare system to really take care of us and to provide us well-being and health. And that simply isn't enough, because really health stems from every segment of our community. We have to have healthy and safe community environments. If people don't have safe places to walk, lighted streets, etc., and don't feel safe going out, they're not going to get exercise. They're not going to engage in activities that might improve their health. We certainly need good medical care. And that medical care needs to focus on preventive care, because we know by vast amounts of research that expensive care does not necessarily equate to good care. And we know that expensive care really comes about because of lack of intervention early enough in the treatment of disease. ACOs are really focused on that issue. I tell my students, you know, who is responsible for your health care? It's not just the healthcare system, it's the patients, it's every part of the community. And we want to eliminate health disparities. And we need to do that by empowering people to be able to engage more in the healthcare system, much as Dr. Hewitt had talked about. So if we do that, we increase the number of Americans who are healthy at every stage of life. And that really should be the ultimate goal of our healthcare system. And in the meantime, we will address many, as you see in the outer circle of this model, we begin to reduce some of these issues in our community. Next slide, please. So there is an interlocking chain of health outcomes. And we need medical care, of course. It's not the only thing that produces good health, but it certainly is an important component. And here ACOs are acting. And of course, ACOs do the traditional types of things, individual diagnosis and treatment and so on. But it does collaborate across the continuum. So we have population health strategies that are serving targeted populations, focusing on the determinants of health, applying new interventions and strategies, and again, data-driven. The new technologies that we have allow us to analyze and to predict and to look at things in ways that we never could in the past. And so we can really produce a much better collaborative experience across all of these sectors. And public health comes into play, serving the entire community with surveillance and identifying risk factors. You know, my feeling is that if we do the best care we can for the least of us, we do the best care for all of us. Because everything we learn about caring for people in underserved communities, or they're disadvantaged in some way or disabled, we really improve healthcare. And that's really should be the goal. And then of course, we have many community stakeholders. We have the Ys, we have fitness groups, youth groups, religious organizations. These are places that people go and trust, and we need to have services and information everywhere. Healthcare should be a top of mind activity for people, or top of mind thought. Grocery stores and restaurants, you know, I'm sure all of you have seen, you know, the things on restaurant menus and in grocery stores that give you information about the nutritional value of things, or if it's for heart diet or whatever. So those are information that, you know, all of our community stakeholders are participating in. So this interlocking chain really helps produce the health outcomes that we want. And many times ACOs are very instrumental in organizing this, because they have been given extra incentives to do so. Next slide, please. So if we think about what are the required inputs, well, we need a focused program. And again, ACOs come into play here. We need community-based networking. You need to know what's affecting the health of the people you're serving in your community. Do you need to get involved in helping get better street lighting? Do you need to create parks? Do you need to have community gardens? What do you need to be doing to really improve the environment? I know in Seattle, I saw an amazing thing where people were taking vacant lots in the inner city and turning them into community gardens. And these were just absolutely fantastic. I was just so impressed as a gardener and as a healthcare person to see something like this. And there were lots of people involved in doing that. And in the other interesting aspect of it is that people in the community could use this garden and grow things. And the only requirement they had was that they had to give part of their produce to the food bank, the local food bank. So everybody in the community was benefiting. And of course, then we produce outreach and engagement. Without the patient's engagement, we're not going to get far, because people need to be thinking about their health and be engaged in improving their own health. Next slide, please. So now we get to a special ACO, the Reachmark, which stands for the Realizing Equity, Access, and Community Health. It's a Medicare program, and basically it is seeking to encourage healthcare providers to coordinate care and improve the care that they're offering to Medicare patients, especially in the underserved communities. And the requirements for this program, you need robust measures of health equity. You need benchmarks that can be adjusted as needed based upon the people that you're serving. You really need to understand the population that you're serving, and understanding that the data that you're bringing in so that you can analyze this information, because you're taking care of lots of people. And so you want to advance health equity by bringing benefits of the accountable care organization to underserved communities. You want to promote leadership and governance, and you want to protect beneficiaries with this model by more participant vetting, monitoring, and transparency. Something that, you know, healthcare hasn't been real great at doing in the past. You know, we speak a different language. We are highly educated, and many times people don't really understand what's happening. So could I have the next slide, please? And here's a little example of a program that really is a co-production of health, where 45 neighborhoods in a local community here in Charlotte, actually, and 25 agencies and some healthcare providers got together to really focus on improving the health of a targeted population in an underserved community. And we had a REACH grant. Now, REACH in those days, this was several years ago, was a little bit different than now, but basically it was a CDC grant, and we focused on heart disease and diabetes and did some really amazing things. We did lots of community health outreach and screening of people. We identified serious illnesses that needed follow-up. And one of the most innovative things we did was we developed community health workers, which was very innovative at the time. These were local people that were seen as trusted members of the community, and people would often go to for advice. And we trained them on healthcare matters and how to help people find the services that they needed. And it was very successful, and it did lots of things. Not only did it improve the health of the community, but it also increased the trust that existed between the underserved community and the healthcare community. Because I remember in talking, and I was part of Healthy Families, Health Communities for many years, and I remember people saying, well, you know, we kind of see you folks as being in the ivory tower, you know, and unapproachable. And that created a barrier to accessing care right there. But this program was quite successful, and I was very proud of it. And it's an example of that co-production where lots of people from different walks of life and different industries and segments of our community got together to really focus on improving the health of a targeted population. Next slide, please. So to summarize, it takes a community to collaborate to produce better health outcomes. That really is the absolute most important takeaway. It takes a community to manage a pandemic or a serious or complex health issue. Each segment of our community has a role to play, whether it's patients, healthcare institutions, government, and industry. No segment of society can do it alone. And I think that's a learning that we really need to take to heart. We found that we have underdeveloped and underappreciated the role of population health management, which as a healthcare executive, I think population health management really is healthcare management. Because if you do that right, you also provide good healthcare, period. And it's so important to overall public health. And preparation is key. Consider the unthinkable, like COVID, because major events will and do occur, and we must be ready through better preparation and collaboration.
I was really pleased to see that last slide. I was just digesting it, and I was probably curious how many of you are actually teaching this as a topic within another course, but that's another question, and we'll go on and take your questions before we come back to that one. As you can see from our three different presentations today that population health management is a complex innovation, and it does have lots of different perspectives, but it's also something that is system-wide. So we feel it's valuable regardless whether you're a healthcare provider or a healthcare administrator or whatever your role is. And consequently, because it is the standard of care now, our students need to learn about it. They need to be exposed to what it is. So what we did in this textbook, in the different sections that we integrated and the 13 different chapters, was we tried to provide an overview, but it's complete. We made sure that we gave lots of interesting materials for not only the students to learn, but for them to integrate into real world experiences. So the instructor's manual is very robust, and there are lots of examples. We took these complex concepts, and Julie's is a really good example of what we took and how we broke it down so the students could learn that risk segmentation. We also talked about the co-production of health with non-traditional partners. So we did try to incorporate as much as possible. I know before I had used pieces from several different textbooks to pull this all together. So that was one of my goals, was to make sure that this text covered all perspectives and was, I think, inclusive enough for public health, community health, global health, whatever, or even your straight health clinician or practitioner experience. On the next slide, we identified, I think, some of the other types of things. We did include podcasts because I know if your students may not be like mine and are commuting in a train into New York City or someplace else, but we do know they like podcasts. So every chapter has a podcast, one by the author, where they pick a topic within the chapter they'd like to discuss, and one by an industry expert that shares, this is how I used one of these ideas, or how I use the skills from this particular chapter. Every chapter also has a mini case study, relatively small, but something that actually applies the concepts that are embedded in that particular learning unit. And then finally, when we talk about the innovation of things to come, we did move on to, this is going to change. We've given you the background, but we introduced the change model. We talk about design thinking, and then we also move into the area of working with non-traditional partners, because as I mentioned in my segment, when we were covering all of the mobile apps that are out there, in healthcare, you are going to be working with a non-traditional partner. Whether that's the retail clinic, pharmacy, another clinic, whether that's a software provider or of a particular app, but you probably will be working with someone like that in the future. So we did discuss those kinds of issues. And those are kind of the teaching tools that are unique to the text, in addition to the traditional ones that has the test bank, some of the suggested activities, the webinars, all the other resources that you would expect. So I think with that, David, do we want to open it up for questions for everybody?
Yes, please send in questions that you have about the presentation or about teaching a course on population health. I do have a question to get the ball rolling. Given that this isn't a practical applied type text, what skills do you think are most important for the future healthcare leaders of the world, future healthcare leader nurses, future healthcare leader public health professionals on this topic that you think every student at that advanced undergraduate to graduate level really need to hone?
I think that's like asking which is your favorite child. It's not an easy question to respond to, but I do think I would say they need to have an essential understanding of both of all three elements to begin with, And then I think what I just alluded to in the last chapter was that going forward, knowing the change management, the design thinking that's behind it, is going to help you inform some of the skills that were outlined by what Steve and Julie talked about with the risk segmentation and also learning to partner with traditional and non-traditional partners.
Yeah, I think just to add briefly, I think that we need to learn to meet people where they are, whether they're patients, our employees, people that we work with. I think that we need to kind of drop some of the formality that we've always had in looking at situations and try to understand where people are coming from in order to better serve them. And I think that is something that you develop by being in the community, by understanding the people you're serving, by talking to people, and doing community assessments, etc.
I would just add one more comment and then we can end this question, which is the beauty of what we've crafted is that it's not just from an academic point of view. It is from all of us in the industry that are seeing patients to those that are managing patients, those that are assessing, what is those case studies and what are those opportunities. So it's a real practical guidance coupled with the academic elements that are really critical to being successful in this space. And I think that's also the beauty of who should be looking at this, who should be looking at these chapters and who could actually flourish in those opportunities, because it's not a one size fits all, which is really the beauty of it.
Great, thanks, Julie. There's a question from the audience. Does your text also have a global section in terms of other industrialized countries as compared to the US system? You mentioned global, I think, Annie, at one point, that perspective. Can you elaborate on, I guess, global topics or global content?
I think we used it in the context that many of these skills are applicable wherever you are. And once you learn the essential skill, the ability to scale it to whether it's just a neighborhood, to the community, to a region, and also to a country. We didn't go into an exceptional amount about global health, but I think that's covered in the sense that we also talked about how these different skills are transforming, and also going back to the idea of knowing your populations. So global health is following a lot of what we're talking about here in population health. When you think about the World Health Organization and their initial efforts to stratify out during the pandemic what countries were at risk, what particular populations were at risk, all of that is just based on these types of skills that we already discussed.
Great, thank you. Another question. So what innovations right now relate to behavioral health have been incorporated into population health management? I know behavioral health is on a lot of minds because of aftermath of the pandemic, or during the pandemic, that's become a major issue. Can you address maybe how this population health management addresses that or could address it?
I can take that. Well,
go ahead, Steve.
I was just going to add one example. Excuse me. One innovation that's occurring is that behavioral health is being embedded in primary care practices, because there's such a shortage of behavioral health psychiatrists, psychologists, and so on. They're embedding through technology practices into primary care offices. And so when the primary care practitioner is identifying people that may need behavioral health services, they're offering a quick consult via technology with a mental health provider. And because we've identified that about 25% of people that come to a primary care office have some identifiable behavioral health need. And so this is one way to really improve access, because there's such a shortage. behavioral health people.
Thanks.
I would just add on top of that for our audience that we know behavioral health and rural health patients and consumers adopted the virtual care and the technology at a higher level than any other category of patients. And they continue on with it. They were the population at risk of not seeing their healthcare provider and needing to have that regular contact and interaction. So they adopted the telehealth during COVID far more than other particular areas, just to keep that continuity of care going along.
Great. Another question, will public health agencies and health systems continue to partner in the future? And what do you see as the kind of outlook of things to come, considering these innovations that are happening?
I think it is the future, but that's my take. I'm gonna also ask Julie Mascari from the industry side if she sees it as the future like I do.
Yes, I was waiting for you to finish, Annie. Absolutely. It is, you know, Steve said it brilliantly when he wrote out and he said community-based networking. And I think that's the reality of it. We are going to have an integrated model. And the integrated model has often been defined as that interdisciplinary team. Well, we need to extend that interdisciplinary team beyond just care managers and behavioral health professionals and your PCP. We have to look at it beyond from those social determinants of care. And how are we looking at ensuring that you're getting a Meals on Wheels delivering to your home? So we're extending it out. How are we looking at ensuring that you're getting your Wi-Fi paid for so that you have access outside of your home? Or are we picking you up in front of your home for transportation? These are all examples of how we are going to be assessing that full model to take care of that whole patient and not just their clinical needs. So in the very simplest term, it will be the future, and frankly, it's the present. More now with COVID than ever did we realize in the last 2 years that all resources available to help our patient base, because they weren't going to the doctors, we needed to bring to them. So home care was brought to them. As I mentioned, meals were brought to them. We were delivering their prescriptions, we were bringing to them. So all of these outlets will be brought to and center around the patient versus being very disjointed. It's not just the future, it's the present and the near, very clear present future.
Yeah, I'll piggyback on that one other thing. And Steve and I a long time wrote an article about some of the challenges when you are working together from a not-for-profit perspective and a public perspective and a proprietary or third care provider perspective. So within our co-production of health chapter, there's a whole unit or a whole little module built on understanding the thinking behind a nonprofit, how now I'm working with somebody from public health, now public health is working with someone that is for profit. And what are the challenges when we go to collaborate those different types of organizations? So I guess maybe we did think it was the present and not just the future when we were putting this all together, because that is in there as well.
Thanks,
Yeah,
Andy.
I like to use my little moniker that you can also do well by doing good.
A good thing to end the Q&A on. Well, okay, that is all we have for today. Here's some information on the textbook. We hope you enjoyed the webinar. Please visit us at www.springerpub.com/population-health-management for more information about the textbook, or feel free to send any questions and comments through email. And let's see. Got some thank yous. So good job, everyone. Thank you, Annie. Thank you, Julie. Thank you, Steve. It's been a pleasure working with you on the book, and we look forward to many people using this as a tool in their new courses on population health management, or maybe they've already had a course for a long time.
Yes, thank you all.
All right, thanks everyone. Take care.
Bye.
Bye.